Let's move on to some of the data we saw at ASCO today in the oral sessions. You know, we're trying to move the bar forward and looking at optimizing treatment for patients with EGFR mutant lung cancer. And, you know, this speaks maybe to the heterogeneity of EGFR mutant lung cancer, but we're starting to see signals of adding chemotherapy or anti-angiogenesis drugs up front that may lead to improved outcomes. So, Ross, you want to tackle abstract 9001, which was essentially looking at gefitinib versus gefitinib plus chemo, some of the data we saw last year at ASCO and another data set now.
So it was wonderful on several levels. So one, it's the first really good data I've seen coming out of an Indian institution, tremendously enthusiastic and very impressive presenter who, this was a homegrown study. So EGFR mutant patients, several hundred patients randomized to getting gefitinib or gefitinib plus carboplatin and pemetrexed. And it was quite dramatic. It increased the response rate. It doubled the PFS from something like 8 to 16 months, so it's easy to figure out the hazard ratio at 0.5. And then it even increased overall survival. Now, with overall survival, the issue is in that setting, the ability to get next line therapy may be problematic. For example, in the control arm, only 30% of people actually got chemotherapy. So there's an element of you're just stacking the deck up front. But it really makes you pause for thought. Yeah. Is this something that is the best thing for our patients? Recognizing that there's an element of kind of back to the future with this. It's kind of like, so we're going back to chemotherapy after we said, great, you've just got a pill. Yeah. So it really makes you think about whether you could have that discussion with a patient and say, look, there's this data out there. Okay, it was a single site, it was a big study, it was randomized, but what do you think about adding in some chemo up front?
Are you ready to extrapolate and add it to osimertinib? I mean, we've got 2 data sets now showing that chemo added to first generation TKI leads to these whopping improvements in OS that we don't normally see. Yeah. Is it a consideration right now? I mean, I know it's not approved, but is there a patient where you may think, look, I've got this data with first generation TKI showing a survival advantage, symptomatic patient, think you can tolerate very young, would you add chemotherapy ever?
Well, the great thing is, so the 2 concerns are, one, it wasn't done with osimertinib, right. And 2, it was a single institution in a country that's not necessarily entirely reflective of our own healthcare situation here. But the good thing is there is a big pharma study. FLAURA2 right. is osimertinib plus or minus chemotherapy, yeah. which is going to answer that question.
Yeah, so I look forward to having that. I think that the trial design is important to have to answer the question, does chemo add anything to osimertinib versus osimertinib?
It builds upon NEJ009. We did have another similar study out of Japan which showed essentially very similar findings. So I think this is a theme that we're seeing over and over again. I think it'll be really important to see this data with OC because there is increased toxicity, practical considerations, that aren't completely, we can't discard. But I think for really, good improvement, I think people will adopt this. Yeah.
And we should be clear: this is adding in chemo, not chemoimmunotherapy.
Correct.
Yes.
And that may be if we're drifting away from chemoimmunotherapy in EGFR mutant, this may be a blessing in disguise as a way of getting that message home.